But to move forward with this, and it's on recovery capital, is what we're going to be discussing today. And I just want to do a little background of, I'm 62 years old. I've been in the addictions profession for some time. Right now, I'm a professor at a university, have been for 7 years. Prior to that, I worked for Adams boards and Addis boards, direct practice, private practice, jail services. I'm married. I have 3 daughters, 3 dogs. I mow the grass. We got a nice little historical home in a suburb. And 38 years ago, I was a felon that was amongst Cleveland's homeless, moving into winter. And I am someone that is in recovery from addictions. I've been in recovery from addictions for a long time. And what I want to do is thank everybody on this panel, because I am a beneficiary of your works. I am a beneficiary of a primary care physician, David Brill. He works out at Cleveland Clinic. I love the guy to death. I want him to be the one that pronounces me dead someday. He's constantly checking in about my recovery. He asks me if I see him once a year, just if I was a diabetic, he's going to do the blood work. Every time I see him, how are you doing with the meetings? How are you doing with the recovery? He's given me holistic options for pain relief. When I fractured 7 ribs a couple of years ago, my recovery is front and center for my physician. I'm a beneficiary of a sentencing judge, Stephanie Tubbs Jones from 1983, that felt wise to force me into a treatment programs that I didn't want to go into. I'm a beneficiary from all those people that worked in the healthcare profession that saw me for what I was and helped me along. And I truly needed every one of those interventions along the way. And I still need that support today. So what underscores everything in my life, from a 31-year marriage all the way through to my current job, is I am in recovery. And I am one drink away from going back to where I was once upon a time. Now, what we're going to do today for some learning objectives real quick is really understand the importance of recovery capital. And not just for an individual, but recovery capital for a community. Because what the community has can basically help predict if somebody's going to have some successful outcomes or not. So we need to look at this from both a micro and macro perspective. I'll give you some links to some various recovery support instruments. But first things we have to do is figure out what recovery is in the first place. And we have not had success in finding a lot of a very concise answer to this. There are some people that define recovery as complete abstinence from mood-altering substances. So that would mean that somebody in the Supermax prison in Youngstown that gets to see light 1 hour out of every 24, that doesn't experience a human touch the entire time they're there, and has no interaction with any other human beings outside of verbal. That means they're in recovery because they're abstinent. Physically abstinent from mood-altering substances. And it's so much more than that. When we're working in treatment, it's really hard to aim for a goal when we have so much ambiguity in what the definition of recovery is. A few years ago, the ADM board and United Way funded a local research on this. And one of the recommendations were that each level of care within the system defines what successful completion of their level of care is. What is the target? According to SAMHSA, successful treatment is abstinence at discharge. But yet, if somebody's going through detox, it's kind of hard not to be abstinent at discharge from detox. So is successful detox more than just that physical abstinence? Now, there's a couple of definitions I'm going to show you, and I'm embarrassed to say that I have been on, and I know some of you have been too, I have been on some committees that were charged with coming up with a definition of something. And what my experience is with those committees is everybody in the room has to get their favorite buzzword in there somehow. So a lot of times committee-based definitions could be choppy, they can be complex, and this is one from SAMHSA. SAMHSA's working definition of what recovery is. It is a process. And in the several definitions I'll show you, process is a key word. It's not a result. Even when we get into 12-step groups, they talk about recovering. I am recovering. I am not recovered. And there's been a lot of debates on that over the years. But it's a process of change through which people improve their health and wellness, live self-directed lives, and strive to reach their full potential. There's 4 major dimensions that support recovery: health, overcoming, managing one's disease; home, have a stable and safe place to live; purpose, and this really needs to be emphasized. Purpose, conducting meaningful daily activities. Every human being wants to have a purpose, wants to feel fulfilled with what they accomplish. And community, having a relationship and social networks that provide support. So right off the bat, SAMHSA's working definition isn't only about the individual. It involves others. In a 12-step program, the very first word in the very first step is we. It involves others. Now, another definition, this is by William White, and William White is a known researcher. He is one of the leading advocates of the recovery movement. He has written a couple books on recovery history. One is called Slaying of the Dragon. But he talks about recovery is the experience, a process and sustained status through which individuals, families, and communities impacted by severe alcohol and drug problems utilize internal and external resources to voluntarily resolve these, to heal the wounds inflicted by substances, actively manage their continued vulnerability to such problems, and develop a healthy, productive, and meaningful life. So what that means is, again, this can work for individuals, but it's also for communities. Think about the communities, even in our area, that we need to heal the wounds. Think about what's going on in that small town in Texas. And I know this isn't substance abuse related, but that community is going to have to find a way to recover from that horrible trauma that they experienced 10 days ago. So let's look at this of what we could do for the individual and also what we could do for our community, whether that's our healthcare community, our treatment community, our 12-step support community, our criminal justice community. They've all been impacted by substance use. Now, the Betty Ford panel, and this one's a little older, it's recovery is voluntarily maintained lifestyle characterized by sobriety, personal health, and citizenship. So again, citizenship is, what is my role in the wider context of humanity? What is my role in my workplace, my area, my family, my community? And that is factored into these definitions. They refer to it as 3 stages. There's early recovery, and this is someone that's in recovery for up to 1 year. And this is different from how the APA and the DSM describe it. According to the Diagnostic Statistical Manual, there is early recovery is basically under a year. Recovery would be defined as partial or sustained full remission beyond 1 year. But there's also sustained recovery, they say, is over 1 year and less than 5, and stable is not till over 5 years. Alexandra Laudet, she's a researcher. She used to work for IRETA. Now I think she's affiliated with Texas Tech. She's consulted with SAMHSA. She has some ongoing longitudinal research. She is one of the only people that I've known that actually studies folks in long-term recovery. And she has longitudinal research. I'm actually a participant in this, that I'll get a survey about once every year, and I have been for years, and submit these back. And what she found, it's kind of like Maslow. Maslow tried to identify mental health by going backwards. Instead of focusing on the illness, he focused on what is the optimal human experience, and let's work down from there. So when we get into Laudet's research, she found out that a person in long-term recovery, which she describes as someone of over 5 years, and she came up with that 5-year marker because it's not until someone has 5 years clean and sober that their relapse rates fall below 15%. So if you're a physician and you have somebody that has a year clean and sober, they still have a pretty high relapse potential. If you watch the Lifetime channel movies, which I pray that none of you do, although Russell is beaming with pride right now, like I'm calling him out. So if you watch the Lifetime channel movies, the happy ending is when little Russ gets into treatment. It's not about what happens after he leaves treatment, or once he gets out of treatment, or that 6 months after treatment. It doesn't look at, according to NIDA, that over 50% of people that go into treatment don't even successfully complete it. So we do have to keep people engaged with services for a longer period of time when we do. And some of that can really be undergirded by primary care physicians. Like I said, I'm a beneficiary of who I think is the best primary physician I have ever had, because he's always checking in about my recovery. Now, a little trip down history lane here. And I'm just doing this to emphasize what Recovery Capital is. I work in Polsky Building at Akron. Next door to the Polsky Building is the Mayflower Hotel, which is actually a place of historic significance for the recovery movement, because it was at the Mayflower Hotel that Bill Wilson, a couple months sober, had an urge, and he didn't know what to do with his urge other than find somebody to help. And if he could find a suffering alcoholic to talk to, it would help him work through his urges. Now, Bill Wilson, what a lot of people don't understand is he was a remarkably successful stockbroker. He wasn't one of these high school degreed financial evaluators. He was a stockbroker that had clients like the Firestone family. He had clients that were of the upper 5% wealth, and steel barons and rubber barons and these big industry magnates. So when he came here, he needed to reach out to somebody that was suffering. So he called one of the Sieberlings. And the Sieberlings were the folks that lived in that Hyatt Hall or whatever it is, which is almost a museum of a mansion. And they hooked him up with a physician that was known to have an alcohol problem, that was in and out of detox, that had shaking fits, and he was a surgeon, in fact. So you don't want to have, I don't understand surgery, but I know I don't want to have a doctor with the shakes and sharp objects by my being. So he had a meeting facilitated by one of the richest families in Summit County to meet a physician, and they met at the gatehouse of the Stan Hyatt Hall. So you're talking access to places that most people don't go. So it ended up Who he met with was Dr. Bob Smith, who has a placard in front of him and began one of the first 12-step friendly drug and alcohol treatment programs in the world at St. Thomas Hospital. So his house up on Ardmore is on the National Registry of Historic Places. And there's people from AA from all over the country that make pilgrimage to Dr. Bob's house every June when AA was founded. But a little bit about these two. Bill Wilson was a low bottom drunk, but when he got sober, he was still a homeowner, he was married, and he was a stockbroker that had contacts all over the country. When Dr. Bob got sober, he was a low bottom drunk when you look at the physical addiction piece, but when he got sober, he was still a licensed physician working at a hospital that was married and a homeowner that had no college debt or anything like that. So those are the two men that got sober and launched Alcoholics Anonymous. Both had a tremendous amount of resources that put them in a better position for success than a lot of the clients we have. So let's say in that June of 1935, it wasn't Bill and Bob that had that meeting, but it was Betty, a homemaker from Akron in 1935. Only 14 years away from her right to vote. A white woman in 1935 America didn't have a voice in a lot of things, didn't have the options to have jobs or vocations or even get into many colleges. And let's say who she met was Satchel, a 35-year-old African-American man in 1935 United States of America, that wasn't even allowed to drink in the same fountains, go to the same bathrooms, or go to the same restaurants as everybody else. Would those two, if they were as motivated and as smart as Bill and Bob were, been able to launch something like Alcoholics Anonymous? And the answer is no. And what we need to realize is that in our services, in many of our services, we treat more Bettys and Satchels than we do Dr. Bob's and Bill Wilson's. You know, I've worked in addiction treatment for over 20 years, whether it's private practice or in agency work. I have never had a patient that was a successful New York stockbroker. I have never had a patient who was a surgeon. And I know they're out there, but those aren't who really run to a lot of our treatment programs. So the term recovery capital refers to the quantity and quality of internal and external resources someone could bring to bear to initiate and sustain recovery. And there's four types: personal, family, community, and cultural. Physical are they physically healthy? Do they have financial assets, good credit, health insurance? Do they have safe recovery, conducive shelter, clothes, access to transportation? Is this somebody that has strong moral values, a strong moral compass? They have a vocation, a license, a trade that they can fall back on. Their problem-solving capacities, self-awareness, self-esteem, self-efficacy. Are they hopeful? Do they have a sense of purpose? Do they have interpersonal skills? You know, if somebody's on the autism spectrum disorder, that is going to impede some of the interpersonal skills necessary for someone to fully assimilate into a recovery community. It doesn't mean that they want sobriety any less. It doesn't mean that they're less intelligent, and they might even have a skilled trade. But those kind of human recovery capitals are important for us to look at. So if I have a patient, or if you have a patient that's on the autism spectrum, do I just give him a sheet of here's where some 12-step meetings are in your area, go? Or do I need to realize that they're going to need a different type of intervention and a softer landing spot than going into something as socially intimidating as an open 12-step meeting? There's family, which is, where's their intimate relationships, their family? Is my family supportive of my recovery? Or is my family, the lords over a known drug house in the community? Those things matter. Is there presence of someone else in recovery in somebody's family network? My wife and I, we've both been clean and sober for a long time. And there's been often times we get a calls of, your brother-in-law told me you were sober. Your sister-in-law told me that you might have a problem or need to talk. So our sobriety even gives a greater resources within our family scopes. Access to sober outlets for leisure. And there's also community. What is the stigma like in your community? We found some of these in rural Ohio, and I know this from going out with Doug and Russ on some of these sequential intercept meetings in the communities. And there are some communities that are very open to medication-assisted treatment and building those resources. And there are some communities in Ohio, for reasons that are their own, that have no willingness to even look at the option of medication-assisted treatments, despite the science, the recommendations, or the degree of the problem that they're having. So if you have a patient that is heroin addicted, and maybe they are on an MAT, they might encounter some stigma barriers even in the recovery networks in those communities. So we need to be aware of those kind of things. Cultural. Is there culturally prescribed pathways of recovery? Somebody brought up earlier going out to something about Native Americans. And Native Americans do have, there's the White Bison movement. There are recovery-oriented programs that are culturally focused. I've been blessed with the opportunity to go to a recovery meeting on a Native American reservation a number of years ago. And it was very uncomfortable for me, because one of the things that's sacred in the culture that I was invited to is the circle. There's something sacred about the circle. So during the entire meeting, everybody sat in a circle in a lotus position, which I am not good at. I am just not good at right there. So I sat uncomfortably, but you had to hold hands with the person on either side of you the entire time during the duration of the entire meeting. So this was, of course, pre-COVID. And what I realized is when it was my turn to share, how awkward and vulnerable I felt sharing with strangers while I'm holding hands with two strangers. But that was how they did it there. And it was very unique and very different from what I'm used to. So are there those kind of culturally sound meetings? Some people are more comfortable with their demographic. So is that something that we need to look at when we refer them to outside resources? I know in some major areas, there's Afrocentric programs, there's urban minority and alcohol and drug outreach programs. There is, and some folks really want to feel more at home with people that have had the same life experience as them or from the same culture as them. And we need to recognize there's value in that. So recovery capital problem matrix, it's really just this quick little box that we could describe our patients based on recovery capital. So high recovery capital and low problem severity, or low problem severity and low recovery capital. We have to look at where somebody is on this particular matrix. So let's say that you have two patients. One of them, they are both opiate use disorder, 304.0. They are both using street heroin at 1 gram a day. So that's about 10 bags of heroin a day. So 10 bags of heroin a day, that is their habit. They go through physiological withdrawal that's pretty severe if there's sudden discontinuation, and they are very frightened of that. And both of them are trying to augment all that angst around the with maybe about 20 milligrams of Valium on top of it. So both physiologically have the same issue. One of those individuals, well, we'll say that individual that has the 10 bags of heroin a day combined with Valium has a career, they are an attorney, they have really good healthcare insurance, they live in an environment where their wife is clean and sober and their brother-in-law is clean and sober, and there is no drinking at family gatherings. There's a tremendous amount of local resources where this individual is at. They have stable housing, their home is paid for, and he's got a 790 credit rating. But he's a bundle a day heroin user. So that is high problem severity, but high recovery capital. Now you have another individual that is only drinking alcohol on weekends. He has 3 OVIs. He doesn't have physical withdrawal, but he's a high school dropout. He's unemployed. He has no trade skills, a felony conviction, so he can't get student loans or anything like that. Unstable housing. He's couch surfing from using friend to using friend, and he has no transportation because of the multiple OVIs. His problem severity is fairly low by being a weekend warrior with alcohol and marijuana. But with his low recovery capital, which one of these 2 patients do you think might have the most complex treatment needs? Which one of these 2 individuals do you think might have the lower prognosis for recovery? Is it the one that's more severe with high recovery capital and support, or is it the one that's not as severe that really has no recovery capital? So this is one of the reasons we can't have those cookie cutters based just on problem severity. What resources someone brings to the table are important. So how do we measure it? Some strength recovery items are exercise regularly. And exercise is underrated sometimes. And I know as when we think of prescriptions, oftentimes we think of prescription in terms of pharmacology. There's one study that I show students in a psychopathology class. It's a comparative analysis of amphetamine therapy versus aerobic exercise for adolescents with ADHD. And when we looked at symptoms reduction on this study, and I'm even going to send it to Nicole so she could send it out, because forgive me, I forget the author's name. It's the aerobic exercise had greater symptoms reduction than the amphetamine therapy did. But yet we so often don't look at that as something that we want to prescribe. If we get into, do they have a general practitioner? Is this somebody that has a GP or a PCP? That's actually a strength recovery item. Do they have a regular doctor visit? And if so, can we talk to that physician to see if they could do a recovery checkup to just check in on them periodically? Their nutrition, taking care of their health, they have a driver's license, maintain a bank account. All of these are strength items. Barriers are mental illness that's untreated, use in the emergency room as their PCP, regular use of health services, smoking, no driver's license, been arrested. All of these are barriers. So we want to look at somebody's recovery capital even when we're doing treatment plans. Now, when Nicole Amon, did I get it or did I get it wrong? I get it wrong again? I can't help myself. It's like an accent. So anyway, I'm from the west side of Cleveland. We don't have traffic circles or museums or anything, so I struggle with, enunciation. This is going to have a link to some of these recovery assessment instruments. And There's one for an individual, there's one for an agency, like a treatment agency, and there's even some for communities that you can look over. So those are just some background on recovery capital. Now, a few years ago, like I said, we did this little study that involved looking at people in recovery locally. And we found out some of the questions that we asked them is how long they'd been sober, was their physician aware of their recovery, are they confident their physician understands their recovery, does their physician understand their recovery before prescribing medications, a number of questions like these. And some of the results, and I know I'm not going to be able to go to many of these due to time, but in this survey, we surveyed people in recovery, and we also surveyed people that work in treatment programs. So the N was low. The N was only 167, which is low. So I'm not going to say this is generalizable across a large population. But amongst those people in recovery, we asked if recovery can only occur through complete abstinence of mood-altering chemicals and including MATs. And what you're going to see is they were all over the place. So while there is some in recovery and there's some that work in the addictions field that really believe that recovery is more than that, there's a large number of people that don't. So sometimes with my graduate students, I ask them on the first day, do you believe addiction is a disease? And I tell them up front, I don't care what you've been taught. I really don't. I care what you believe. Because as human beings, what we're taught and what we believe are not always the same thing. And I'm always amazed by how many people that are getting into the helping profession really don't believe in the disease model of addictions. I was kind of stunned. I was kind of taken aback the first time I asked that question, but I have to understand this is where people are. So this is my recovery support group. So this is only for people that were in recovery. My recovery support group is open to people on medication-assisted treatments. 23%, so 1 out of 4 of folks that go to recovery support meetings don't believe their support group is open to people on medication-assisted treatments. So how can we address that down the road? How can we build confidence with our healthcare system? Now, this one is my physician or dentist considers recovery before prescribing medical treatments. And what we had on is 12.5% persons in recovery didn't even want to tell their physician they were in recovery for fear that they would treat them differently. And if there's anybody in at least my world that I need to be completely honest to, it's my primary care physician. And my wife tells me her, because as an insurance agent, she says it's a felony to lie to an insurance agent. So according to my wife's logic, if I lie to her, it's a felony. So I have to consider that too. So what we know is ingredients of recovery capital can be predictors in recovery outcomes. Social supports, spirituality, 12-step programs, affiliation, 12-step affiliation are all linked to achievement in short-term recovery. Access and retention in treatment are predictors of recovery. And having more people to talk to about important things is strongly associated with the strength of someone's recovery. So if Doug is my psychiatrist, and I told him everything, but he is the only person I talk to about all this stuff, that's a good thing. But I would have a stronger recovery if I shared that with more people than just him. And that's the value of that recovery network. And maybe that's 12 steps, maybe that's church, maybe that's a runner's club that you could be honest with, maybe that's people you go to the gym with. Uh, it could be a culture of triathletes. Not that anybody would venture into that crazy group. What we can do. What resources do your successful patients find the most strength from? Learn from them. If you have long-term people on your caseload, what has worked the best for them? There are also resources. If you're in a private practice or you're a psychiatrist and you have some of your patients in recovery and on MATs, ask them, hey, is there some meetings you have gone to that are more open to you talking about this than others? And could you share where those meetings are with me? And try to learn from those successful people. What resources do you rely on as a professional for people with high problem severity? Is there a certain program in your community that works really well with vocational training? Is there something in your area that works really well for social and leisure activities that are drug-free? And what do you rely on and keep using that? Or what do you find most success with? What recovery supports are most needed for your patients? And again, on this survey, we asked the persons in recovery if they'd relapsed. And of those that relapsed, what did they feel triggered that relapse? And number one on the list was romantic involvements. Number two on the list was financial stress. So number one and two on this list was romantic situations and relationships, and number two was debt. And yet, when we looked at every treatment agency that we were working with at that time, not a single one of them offered couples therapy, and not a single one of them offered debt repair. So sometimes we focus so much on the individual and their between the ears issues, we don't look enough at their context and what's going on with them. And I could tell you as a person in recovery, even in 12-step land, there's this belief that no relationships for the first year, none. It's this what you should do because you're not ready for it. We can't have it. I've been in recovery and going to 12-step meetings for 37 years. In 37 years, I have met two individuals that stayed out of a relationship for their first year. One is Father Pat, and Father Pat was not allowed to be in a romantic relationship in the first place. And the second, and this is going to sound horrible, but it was an individual that earned the nickname with a very mean group of new people in the program, of which I was one, and his nickname was IV. Not IV for IV drugs. His nickname was IV for involuntary virgin. He's somebody that wanted to be in a relationship really bad, but he didn't have the, I'll just say, personal hygiene necessary to allow someone that he liked to get anywhere near him. So there was that. So we know people are going to get in relationships, but we don't coach them on healthy relationships very much at all. So those are just a couple things. I might have gone over, but I'm just going to stop sharing my screen and then